Okay, so for this video, what we're going to do is we're going to progress through hypovolemic shock. With hypovolemic shock, I want you to think about the various stages of shock and what's going to be going on with your patients during the stages based off what we're going to see with the patients. Okay, so we're assessing our patient. We think the patient may be in hypovolemic shock. We're going to check our ABCs are always going to be our focus. We're going to look for a focus assessment of the tissue perfusion, and we do that by assessing vital signs. Peripheral pulses, remember how they're going to progress. Talk about the level of consciousness. Talk about your capillary refill. What do you think is going to happen to cap refill? What do you think is going to happen to the skin in the various stages? And then urine output. I need you to think about what are some events that may lead to shock. What patients are going to be at risk and why are they at risk? Be looking for the who of might be going into hypovolemic shock. The onset and the duration of the symptoms. Was the patient like this when they came in? Were they like that all last shift? What medications are they doing? What allergies, and have they had recent vaccinations, or do they need vaccinations? So as you're beginning to walk through the nursing process, I need you to plan, does this patient have adequate tissue perfusion? Can we restore the normal baseline? Can we recover the organs that maybe have been damaged? Can we avoid complications? And then let's prevent healthcare acquired complications. So for our interventions, remember that we're going to think about what medications might these patients need. So if a patient's hypovolemic and the patient has signs and symptoms of that, then we would replace the volume with either crystalloids or colloids. And we'll also use lactate ringers. Now, why do you think we would use lactate ringers? In hypovolemic shock, as acid's building up with lactic acid as the byproduct, we give lactate ringers to actually buffer the acidosis. They may give colloids, those are like your albumins and those type of things. If the patient is actually bleeding or losing blood volume, like from an injury or maybe from a surgical incision, then we would actually consider using packed red blood cells and plasma replacement. So we got to increase our cardiac output, right? So how are we going to increase cardiac output? The primary goal of drug therapy with this is to increase venous return. And we know that we can increase venous return by using a vasoconstrictor. We can also use inotropic agents to increase cardiac contractility. And then also we can use agents to actually help with myocardial perfusion, things that would dilate the cardiac arteries, the cardiac vessels, to help ensure that the heart is getting as much oxygen as possible. If we're looking at those and trying to figure those out, there's a really good chart in your book, and it talks about norepinephrine and how it actually works. How it works is it has vasoconstrictive properties, and when it has vasoconstriction, it increases venous return to the heart, and it also increases the myocardium contractility, so the heart can beat harder. So that's one thing to think about as far as the vasoconstrictor goes. The inotropic agents, with the inotropic agents, that would be like your dobutamine and the milurone. What they do is they stimulate the heart muscle to squeeze harder, so you get more cardiac output with each time the heart squeezes, and that's a benefit to the better your heart squeezes to push the blood forward, the better you're going to have perfusion take place. And then another thing that might alter cardiac perfusion would be like nitroprusside or nitroglycerin. What those are actually going to do is they actually cause vasodilation, which is kind of like blood pressure is already low. Do I really want to give something that's going to cause vasodilation? But if you're trying to get more blood flow to the heart, then you may need to give that vasodilator in that particular time. Remember, with sodium nitroprusside, one of the key things that you want to follow through with is protecting nitroprusside, because it is light sensitive, and you got to make sure you leave it in the brown bag. So when you're pulling that out and you're opening it up, it comes with a brown bag with it. Make sure that you keep it in the brown bag. That's a safety thing, maybe on NCLEX. I've seen that on several different things. Again, remember to look at the drug therapy in your book under hypovolemic shock. So for your nursing management, what are you going to do? These are the things that you're going to evaluate. You got to make sure you're looking at the baseline, EKGs, ECG, blood pressure, central venous pressure, pulmonary artery wedge pressure. Make sure that you're thinking about the skin temperature. Are they progressing? What's the urine output? What's going on with that? Is it dropping below 30 mLs an hour, or is it greater? Or is it less than 0.5 mLs per hour? What are the respirations? What's your O2 sat? Listen to your patients' fears as we're talking about what they're telling you. So what is your role in all of this? Your role in all of this is to educate people how to prevent shock, monitor people that are at risk for shock, and then what should you teach your patient? So if you think about what you should teach your patient, summer's about to be coming. Make sure patients are drinking plenty of fluid when they're outdoors so they don't get dehydrated. Make sure that you're teaching young people to use safety equipment and that kind of thing. Seat belts are a big thing so they don't get injured in a motor vehicular accident. Your job is to recognize changes in the vital signs, monitor surgical site infection, even teach patients what to look for. Is there redness? Do you have fever when they go home from the hospital? Also monitor urine output, monitor for constant thirst or change in the mental status. Is their pain getting worse and you can't really put your finger on why? Have patients even think about that, like all of a sudden they're more thirsty at home. Educate them that could be an ominous sign, or if they have bleeding when they get home, to make sure that they report that back to their provider. So here's what we're going to assess. Again, I've already mentioned these once. We're going to go forward and we're going to talk about them a little bit more. So cardiac changes that you're going to see. What's going to happen in the initial stage of shock for somebody that's hypovolemic? What you're going to see, the first sign is that you're going to see an increase in heart rate. The heart rate's going up because you got a problem going on and the patient's not getting perfusion. So the first thing the body does is increase your heart rate to try to keep your cardiac output up and try to keep your MAP at a normal level. So first sign in the initial stage is going to be increased heart rate. As the shock progresses and the pulse is going to get more and more difficult to palpate. So initially it's going to just be, not as strong as it was, and then it becomes weaker as the shock progresses. Remember, in the compensatory stage it might be weak. In the progressive stage it's going to be weak and thready, and then in the final stage you may not even be able to feel it. O2 sat, what do you think is going to happen with that? In the O2 sat, we're not going to give everybody that comes in oxygen, so we're going to make sure that SAT stay at 90 to 95%. They may or may not. In the compensatory stage, they normally will stay there. As they progress to the progressive stage, often you'll see the O2 SAT drop 75 to 80%, and then in the refractory stage, you'll actually see the O2 SATs drop below 70. So that's the cardiac changes that you're going to see. You're going to see changes in the blood pressure, starting in the compensatory stage primarily. Remember, in the initial stage, all you may see is that the diastolic blood pressure goes up just a little bit. In the compensatory stage, you remember that you're going to see a narrower pulse pressure as that diastolic gets closer to the systolic. One thing you want to make sure that you're doing when you're checking the blood pressure in these is that you're comparing them accurately, apples to apples. So you want to make sure you're using the same cuff, the same equipment, use the same extremity, and then you can make sure you understand that you can always validate that blood pressure with a manual blood pressure cuff. Respiratory changes that you're going to see throughout the stages of shock and hypovolemic shocks. The body's trying really, really hard to get oxygen into the tissue, so the patient's going to be tachypnic throughout the various stages of shock. Another thing we got to think about early in shock, we're going to see that urine output decreases to less than 30 mLs an hour or less than the 0.5 mLs per kilogram per hour. Your job is make sure you're measuring that urine output. You want to measure it at least every hour. If hypoxia or anoxia persists beyond an hour, your patient's going to be at risk for acute kidney injury or kidney failure. So what are we going to see at the skin? Remember, the skin's going to, due to the vasoconstriction, it's going to become cool to cold. It's going to become clammy and moist as it progresses. Where will you see the first color changes? You're going to actually see skin color changes around the mouth and the mucous membranes first. In a dark-skinned individual, make sure that you're looking at the mucous membrane because it may not be able to see it on if they're a darker color. You're going to see changes to the extremity, color to the extremities and to the trunk as it progresses. And the clammy and moist skin, remember, as the body cools and has more vasoconstriction, the skin gets clammy, gets moist. And that's not because you're losing more fluid. It's just because the normal fluid loss from the skin doesn't evaporate the same way on cool skin as it would on normal skin. And then as the condition continues to get worse, you're going to start seeing the mottling going on with the skin. What's going to happen with cap refill is you're going to see that the cap refill gets slower and slower until it may even not respond at all. Think about cap refill, though. It's not always a good indicator, especially when we're talking about elderly people or people that have poor perfusion, like with peripheral vascular disease. Also, people that are already anemic or diabetic, those are not going to be good candidates, or their capillary refill is not going to be the best indicator for changes. So what's going to be your first neurological sign that you may see for somebody in hypovolemic shock? Remember, as we talked about earlier, the first neurological sign that you may see is increased thirst, and that's because the decrease in the volume and the blood volume, and the brain's telling them, hey, we need more volume on board. As far as the level of consciousness goes, they're going to progress from just being restless or agitated, maybe a little anxious, to full-out impending doom. And then they'll end up progressing to confusion, to loss of consciousness. Skeletal changes, what you're going to see is your patient's going to be weaker and weaker. They'll start developing pain as this tissue starts dying. Deep tendon reflexes, they become weaker or less pronounced, and then they'll actually progress all the way to absent as the shock progresses. So your diagnostic studies and labs, I want you to go back and review the chart in your book on those. And then I want you to take a minute and I want you to write down what's going to happen with each of these. What's going to happen to the pH? Is it going to go up or down? And then why? What's going on to actually cause that pH to change? What's going on to cause that PaO2 to change? So just think about those. You take the time. You write those in. I think you filling those out is going to help you way more than me just discussing them on the lecture. So what's your priority? Your priority in this particular situation is inadequate tissue perfusion. So what are we going to do with inadequate tissue perfusion? You're going to make sure to give O2 if necessary. Everybody's not going to get O2, only if they need it. We're going to make sure that we do fluids, fluid replacement, packed red blood cells if necessary, or we may even need to give plasma. Remember, your fluids can be either colloids or crystalloids to replace fluid volume. Lactate ringers or 0.9% normal saline are the medications of choice. And then earlier we did go over the medications, so I'm not going to repeat those again, but make sure that you look over the chart on medications.